Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. It's me, Chloe Gomez, CRNA and educator, and today I am solo, no guests, so don't be too disappointed. It's just you and me, and today we're going to unpack the fundamental topic in anesthesia pharmacology, local anesthetics. I'm going to walk you through the mechanism of action, differentiating esters from amides, toxicity concerns, all of the things. I'll throw in some analogies, real-life examples, and a couple mnemonics to make this topic stick. So grab your notebook, settle in, go for a walk, whatever you want to do. Let's talk about local anesthetics. Hello, my favorite learners. Welcome back to another episode of the My Favorite Learners podcast. I'll just say it a million times. Are you my favorite learners? I think so. Today, we're diving into local anesthetics, as I already said in the intro. So whether you're prepping for my lecture or for boards or getting ready to clinically place your first spinal or do a peripheral nerve block, this information is for you. We're basing all of this on Chapter 10 from the Nurse Anesthesia textbook, Elisha et al., 2023. And we're going to cover these following areas. So 1, we're going to talk about the mechanism of action of local anesthetics. 2, we're going to talk about factors that affect onset, duration, and block intensity. And 3, how to recognize and manage local anesthetic systemic toxicity, or LAST, as we call it colloquially. So let's get started. How do local anesthetics even work in the first place? So local anesthetics work by blocking voltage-gated sodium channels in neurons. So this is like star, 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 highlight, highlight, highlight. This is a boards question. This is a test question. How do local anesthetics work? They work by blocking voltage-gated sodium channels in neurons. So when this sodium cannot enter the nerve cell, depolarization can't occur, so the action potential is blocked and the signal doesn't transmit. That is a very, very simple way to tell you how local anesthetics work, but they work on voltage-gated sodium channels. They do not enter the cell. That sodium does not enter the cell. Depolarization cannot occur. No action potential, no signal. Done. This is why patients lose sensation, including pain in the areas where the drug is applied or injected, however we're administering it, okay? So a really important concept to think about when thinking about local anesthetics is that they preferentially block small unmyelinated C fibers first, which carry pain and temperature, followed by the larger fibers responsible for touch and motor control. So I want you to think of these nerve fibers like strings or cords, if you want to call it, whatever you want to call them. So these unmyelinated C fibers are basically like a little string. They are going to be easily saturated by these local anesthetics, and the pain and temperature is going to be easily controlled because of that. So if you think about it with the larger fibers that are more motor control and touch, that is going to be those larger fibers. That is going to be like a freaking power cord, okay? It is huge. It's thick. It has that casing on it, which is the myelin sheath that goes around the nerve cell, right? So it is going to be harder to block. So the way you can think about this, aside from the string analogy, and there's other fibers in between, like intermediate fibers that are an intermediate blocking. It's like not easy to block them. It's not hard to block them. It's somewhere in between in the intermediate phase. However, clinically, I want you to think about this in terms of an epidural. So I know some of our listeners have placed an epidural. Some of us don't even know what an epidural is and how it works. But essentially, we get into the epidural space, we place the epidural catheter, and we administer local anesthetic. And what happens is the local anesthetic then takes away the sensory pain of their contractions. So why is that? And it's because the local anesthetics saturate those unmyelinated C fibers first. And then once the block becomes denser, whether we are giving a higher concentration of the local anesthetic or a higher volume of the local anesthetic, the block becomes more dense. And that is when women are unable to move their legs during labor. Our goal for placing epidurals is to have a mom with no pain and fully able to move her legs. However, because of the unpredictability of local anesthetics in the epidural space. That is why we don't allow moms to walk when they have an epidural. Safety-wise, we don't let moms walk with an epidural. And the reason is because that block can become dense and you can lose your footing and fall. And you lose ability to have motor function in your legs. So that's something that you can think about clinically when you think about local anesthetics. Well, let's talk about the super basics of local anesthetics and the chemical structure of them. So all local anesthetics share a 3-part structure. They have their aromatic ring, which is lipid soluble. This helps them cross the lipid membranes of the neurons and the neuron fibers. The second part of the chemical structure of a local anesthetic is the intermediate link. This is either an ester or an amide, whatever you want to say. I feel like I say it weird, but you can let me know in the comments. And third, and the ester and the amides have different properties, and we'll kind of go into that later. But the last part of the chemical structure is the amine group, or the end. This is a hydrophilic portion, or the water-soluble portion, and can be ionized at a pH of 7.4. So the mnemonic you can think of is ring, link, tail. The ring is the lipid lover, which is membrane crossing. The link is either the ester or the amide, and the tail is the water lover. So this binds to the inside of the nerve. So why does this structure matter? So only the non-ionized portion, or the lipid soluble part of this chemical structure, crosses the nerve membrane. The ionized, or the water soluble portion, binds to the receptor inside the nerve fiber. So there are 2 main types, like I've already mentioned. So let's talk about the ester and the amide. So there are 2 main types of local anesthetics. One is the ester and one is the amide. And what tells us this is that chemical structure, that link in between the 2 other components of the chemical structure. If you're looking at a picture, it's a little bit easier to visualize, but you can look it up later. So let's talk about the differences between ester and amides. So the structure, there's 1 I in the name of these local anesthetics. So this is the little trick, okay? So lidocaine has 2 I's, right? Amides have 2 I's in their name. So that's how you can kind of tell just by the name of the local anesthetic whether or not it's an ester or an amide. Okay, so let's do an example. Let's look at benzocaine. What is benzocaine? How many benzocaine, I should say, so it's a little bit easier for you to conceptualize. Benzocaine has 1 I, therefore it is an ester. Bupivacaine with 2 I's is an amide. So that's how you can tell the difference between the 2 just based on the name of the local anesthetic by itself. So why does this matter? So esters are metabolized by plasma pseudocholinesterase. So these are broken down essentially in the plasma, in the blood. So examples of those are procaine and tetracaine, because again, it only has 1 I in both of those names, right? Amide has 2 I's in the name, like lidocaine or bupivacaine, and these are metabolized by the liver via CYP450. So more of the traditional route of drug metabolism, we would say. So they are broken down by the CYP450 enzymes at the liver, whereas esters are broken down by pseudocholinesterase. Patients with liver disease may have a slower amide metabolism. And this is also helpful to remember how many I's are in the name and how to tell an ester versus an amide, because if a patient is allergic to ester local anesthetics, which is the more common allergy to have of the 2, although it's pretty rare in clinical practice to see anyone allergic to these things, truly, besides them saying they got Novocaine with epi at the doctor's office and it made them tachycardic, right? The true allergy lies with the more common allergy, I should say, lies with the ester group of local anesthetics. However, clinically, I haven't really seen that many patients be truly allergic to local anesthetics, but it's easier to tell because how many I's do esters have? Ester anesthetic agents have 1 I in the name, as opposed to the amides that have 2 I's in their name. So a little bit easier to remember and definitely easy for a test question. Let's talk about the key concepts of the onset, duration, and intensity of our local anesthetics. So one super important key concept to remember is the more drug staying near the nerve, the faster the onset and the stronger its effect. So the more drug that is absorbed systemically, the shorter duration and the more toxicity risk that you have. So those are 2 key components that we're going to go into, and they kind of dive into each of these different factors and how they influence how fast and how well a block works and how close we can become toxic from or get toxicity from these medications as well. So let's talk about these factors that influence how fast and how well our local anesthetics work. Number one is everyone's favorite topic, pKa. The pKa of a drug of the local anesthetic specifically are very important because the closer the pKa is to physiologic pH, the more unionized the drug is. So what does unionized mean again? Lipid soluble, right? That's how lipid soluble the drug is, and therefore is easier to penetrate the nerve membrane, which speeds up its onset. So the rule of thumb is the closer the pKa is to 0.4, which is physiologic pH, the faster the onset. The high pKa, the more ionized, the slower the onset. The only exception to this rule is chloroprocaine because it has a very high pKa. So as I just said, the higher the pKa, the more ionized or water soluble, therefore slower onset because it does not want to penetrate that lipid membrane. The exception to that is chloroprocaine because it does have that high pKa, but a fast onset because we use it in such high concentrations. And that's why we balance it out in that way. Number two is lipid solubility. So highly lipid soluble drugs like bupivacaine are more potent and have a longer duration. So for example, bupivacaine, like I just mentioned, is 26 times more lipid soluble and 4 times more potent than myfavoritelearners. So just a clinical example comparing the two. I would say I haven't seen myfavoritelearners in the clinical setting, but we are starting to use it a little bit more frequently in some operating room settings for total joints because of speed. So next is protein binding. So the more protein binding percentage of the drug, the longer its duration. So the drug, the local anesthetic, is held in that tissue and can last longer the more protein bound it is. So for example, bupivacaine is 97 is a lot, 7% protein bound. So it lasts much longer than myfavoritelearners, which is only 65% protein bound. So again, like I used in that clinical analogy of using myfavoritelearners for total joints, because our total joint surgeons are becoming more and more efficient and quick for the procedures, we're starting to use myfavoritelearners intrathecally a lot more because it's faster. And why? Less protein bound than bupivacaine, our traditional drug to go to for total joints or spinals or using any drugs intrathecally. Bupivacaine is kind of our go-to in anesthesia. So why? Why is that the case? Why? Because of a drug being more protein bound, why does that mean that it lasts longer? Well, the sodium channel receptors are proteins, right? So because they're protein, the more protein bound the drug is, the more time blocking the channel, which means no action potential, which means no pain, and the more effective the drug is, or the more time the drug is effective, I should say. At what? The voltage-gated sodium channels, right? Voltage-gated sodium channels. I'm going to keep saying that over and over. So by the end of this, if you get nothing else, you know that local anesthetics work at the voltage-gated sodium channels. The next topic we're going to talk about is vascularity of the injection site. So the more vascular the area you are injecting a local anesthetic, the more of that blood essentially washes the drug away and quickly shortens the block's duration. So for example, and this is again a test question, boards question, super important information to know or write down. This is the absorption rate by site from fastest to slowest, which means basically the more highly vascular sites to the lower vascular sites. So first is interpleural, followed by intercostal, followed by caudal, followed by epidural, then brachial plexus, then sciatic/femoral, and then subcutaneous. So what does this mean? This means in terms of the vascularity of the site, the interpleural or intercostal are going to have a very short duration because they're highly vascular. That blood in the intercostals is rushing through there, washing away our local anesthetic. We can't keep up almost to where we have to have that as a consideration in terms of the volume and the dose that we give of those medications. As opposed to subcutaneous, it hangs out for a while. The blood is not coming to wash that away. It's hanging out, it's staying there for a while. because of the lack of blood flow and vascularity in that area. The next topic is dose and volume. I've kind of mentioned it multiple times throughout this lecture, but the higher the dose and volume, generally, both of those things increase the spread and intensity of the block. Makes sense, right? If you inject your arm with a tiny little 1 cc of lidocaine in your arm, it is going to have a very different impact if you do 20 cc's, which I don't recommend. Injecting sub-Q into your skin and feeling the numbness you're going to get once that local anesthetic has its onset and the duration of that. So the dose and the volume really matter. This specifically comes into play in, again, OB, especially when you're thinking about the epidural and the intrathecal space and how much volume and dose we're giving of the medications really in real time make a difference for patients in terms of how much pain relief they get or how much anesthesia they get if we're using it for, say, a C-section, spinal for a C-section. Next is the use of vasoconstrictors like epinephrine. So this reduces systemic absorption and prolongs its duration. So remember how I said that the highly vascular areas, that blood comes in and just keeps washing the local anesthetic away? Well, the opposite is true when we add epi to our local anesthetics. Those vessels tighten up, there's less of a blood flow going to that area. Therefore, that block and that local anesthetic lasts a lot longer at that site. So if you can kind of conceptualize the first portion of local anesthetic being washed away by highly vascular sites, the opposite is true when we add epi. So clinically, we can talk about using epi we'll do an epi wash and add epi to our spinals to make the spinals last longer because of that vasoconstriction that happens and increases the duration of our spinal for a case that's going to go a little bit longer to make sure the patient stays anesthetized by our local anesthetics for longer. All right, lastly, let's talk about local anesthetic systemic toxicity. So this is a serious complication that can occur when too much local anesthetic enters systemic circulation. So how does this happen? It happens with either accidental intravascular injection or when large doses are administered too quickly. So some early signs include metallic taste, tinnitus, so ringing in the ears, perioral numbness, agitation, or confusion. So as toxicity progresses, patients can develop seizures, cardiac arrhythmias, hypotension, and eventually they'll go into cardiovascular collapse. So let's talk about a case where this can happen, okay? So this will hit home for anyone, especially if you've been involved or done OB anesthesia. Some of our learners have not, but this will give you a clinical picture that you can carry with you and remember as you go into the clinical setting eventually if you haven't experienced it yet yourself. So the patient is a 28-year-old G1P0 that was in active labor at 6 centimeters dilation. She requested an epidural, and the anesthetist placed one without difficulty. The test dose was also negative, and 15 mLs of 0.25% or 0.25% bupivacaine with fentanyl was administered incrementally. Within 60 seconds, the patient reported a sudden ringing in her ears and said she felt really weird. She became anxious, started slurring her words, and within moments had a generalized seizure. The anesthesia team quickly recognized that these were the signs of last local anesthetic systemic toxicity. They, 1, stopped the epidural infusion, 2, called for emergency help, 3, administered midazolam for seizure control, or Versed, began airway management and oxygenation, and most importantly, they initiated 20% lipid emulsion therapy with a bolus of 1.5 mLs per kilogram, followed by an infusion. The patient stabilized within 5 minutes and was transferred to the ICU for monitoring and made a full neurologic recovery. So this case is a powerful reminder. Even standard doses can go systemic. Maybe there was a partial intravascular injection, maybe vascular uptake was unexpectedly high. Bottom line is we always have to be prepared. We always have to monitor closely, and we always have to have this last protocol and lipid rescue kit immediately available, especially in OB where rapid changes can escalate very quickly. So I'll give you another clinical example. My sister had her first child and she set up for her epidural. They do the test dose. So essentially, I know a lot of us haven't done OB, I keep saying that, but this is where it clinically becomes really relevant, is we do a test dose. And the test dose is, once we get into the epidural space, we do there's 5 mLs. Some people do 3 mLs. I do 5 mLs, just depends on your clinical practice, of 1.5% lidocaine with 1 to 200,000 of epi in that solution of 5 mLs. So you can give as much as you want or as little as you want. 3 to 5 mLs is standard. And what that does is that tells us we test the epidural. It's exactly that, a test dose. So that 1.5% lidocaine, if the catheter is in two bad places, okay? That's what the test dose tells us. The bad place number one is intrathecal. So if we've accidentally gone through and we're actually in the dura and in the cerebral spinal fluid, that 1.5% lidocaine will tell us, test dose will tell us that, because the patient will lose motor block of their legs pretty quickly, or sensory block and then motor block really quickly, because it goes into the intrathecal space, and that's what the result would be. The second bad place would be intravascular. So that's where the last comes in. And that epi, that 1 to 200,000 of epi that's in that local anesthetic solution, if administered intravenously, will cause tachycardia. Obviously, it's epi. So the patient, my sister, negative aspiration. We always look for heme or blood when we aspirate, when we place an epidural, to make sure we're not accidentally, unintentionally injecting into the intravascular space. That was negative. The test dose was given and her heart rate spiked so high and blood pressure so high, she almost passed out off the bed. Then my mom was standing ahead of her and luckily caught her and kind of stabilized her. And we have sequelae that we do to not use that epidural or whatever we do after that in OB, and make those clinical judgments after that, which is what they did, and they treated her appropriately. But that is a great example clinically of why we do a test dose. And it's one of the ways that we prevent LAST in the OB setting, and one of the safety features that we do to prevent local anesthetic systemic toxicity. So again, how do we prevent LAST? One, always aspirate before injecting. So just like I said, he aspirated on that epidural catheter, no heme or blood was noted, which is why we always aspirate. We're always looking for blood or heme to make sure we're not near a vessel. Use incremental dosing. So every 3 to 5 mLs during a peripheral nerve block. That's pretty much the standard for incremental dosing, 3 to 5 mLs at a time. Consider ultrasound guided guidance to reduce intravascular injection risk. So being able to actually visualize those structures, and limit to the max safe doses, like 3 milligrams per kilogram for bupivacaine without epi, or 4.5 milligrams per kilogram of lidocaine without epi. I can do an entire lecture on the max safe doses of the local anesthetic agents. And if you are listening to this for my course, I will definitely be going into that with you at a later date. So if LAST occurs, what do you do? Just like that clinical picture and clinical scenario I read for you said, 1, stop injecting immediately or stop the epidural infusion, which is what they did. 2, call for help. 3, manage the airway and support ventilation. This helps avoid hypoxia and acidosis. And 4, administering that 20% lipid emulsion, 1.5 mLs per kilogram bolus, followed by the infusion. Seizures, treat with benzodiazepines. So that's the first line of treatment for the seizures, is giving Versed. If in cardiac arrest, use low-dose epi and avoid lidocaine or vasopressin for obvious reasons. If your lipid rescue kit needs to be ready, it just needs to be ready. And at any facility, they have the lipid emulsion or lipid rescue kits readily available on any unit that provides any local anesthetic procedures like blocks or OB for those reasons. All right, let's put this into context. So when choosing a local anesthetic, what are we thinking about? We're thinking about what nerves are we targeting? How fast do we want the onset? How long do we want the effect to last? And whether motor block is acceptable or not. So for example, for a quick IV insertion, lidocaine is perfect because you inject it in the site, you put it works, the onset is quick, you put the IV in and it's good. It's not gonna last forever, it's gonna wear off and we'll be good. For a labor epidural, we want something that lasts a little bit longer. Maybe ropivacaine with epi, because the mom's gonna be there for a long time. We're gonna put her on a drip. And so ropivacaine or bupivacaine are used quite frequently. For a spinal anesthetic, for a C-section, we want a dense motor and sensory block, which is why we choose bupivacaine. Bottom line, always know your max doses. And if you're doing a bilateral tap block or a big volume PEC block, for example, double check your calculations. Also, monitoring your patient is really important. Any mental status changes or tingling around the mouth after a block, we ask that in OB all the time. Ringing in your ears, metallic taste in your mouth, we ask all of those things when we give our test dose in OB, like I had previously mentioned, and that's a red flag. So, all right, friends, let's do a quick recap. So, local anesthetics block sodium channels to stop nerve conduction. Again, what do they block? Voltage-gated sodium channels. I hope you're saying that along with me. Second, the onset, intensity, and duration are affected by pKa, lipid solubility, protein binding, and vascularity. And lastly, no pun intended, last is a serious complication. Know the early signs, how to treat it fast, and have your lipid emulsion nearby. I always ask everybody at the end of the podcast to share a piece of advice, and this is the one that ChatGPT came up for you guys today, which I think is very cute. You're not behind, you're just building. And I'm proud of you for showing up. And that is so true. You're not behind, you're just building. You'll get there every single day, every step of the way. All right, until next time, stay sharp, keep learning. If you have any questions, feel free to send them my way. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.